Good morning, good afternoon, good evening. I'm Meg Doherty, and I'm really pleased to be able to join you today to speak about WHO efforts in the status of global elimination. In the next 15 minutes, I plan to make a case of why large-scale hepatitis screening, diagnosis, and treatment is the way that we can reach our hepatitis B and C elimination goals and targets. Today, I'll be talking about the rationale for acting now, lessons learned from champion countries, measuring impact and program targets, and validation of elimination and the implications for countries. You know that viral hepatitis affects over 325 million people around the world. And for hepatitis B, 275 million people are living with hepatitis, primarily in Africa and the Western Pacific. However, we've seen very good reduction in cumulative incidence through the introduction of immunizations. In terms of hepatitis C, we have 71 million people infected in all regions with an incidence of 1.75 million new infections per year, linked mostly to unsafe healthcare and injection drug use, among other risk factors as well. However, unlike HIV, TB, and malaria, the mortality from hepatitis is increasing. And we've seen that this increase is rising as we have more infections, as it's a long-term from infection to hepatocellular carcinoma. And we've seen 1.3 million deaths in 2015. All of these indicators, prevalence, incidence, and mortality will be updated in 2021. In 2016, the World Health Assembly pledged to reach elimination. And under our global health sector strategy under WHO, we identified 5 core interventions that, if we had sufficient coverage, would lead to a decrease in incidence of 90% and a decrease in mortality of 65%. We know that 2020 is now essentially past, and we're really now working towards our 2030 targets, where we need to step up our game and really work towards elimination. In our global health sector strategy, we have to address both the testing and treatment, but also the prevention. What we need to attain is new infections of only 900,000 by 2030 and less than 500,000 deaths by 2030. And we need to address infant vaccination, mother-to-child transmission, blood safety and injection safety, harm reduction, as well as the diagnosis and treatment. In our global health sector strategy, we've outlined a criteria by which we try to assess our accountability and how far and how well we've done in terms of reaching these targets. For prevention, we're doing fairly well with hepatitis B vaccination, blood safety, and injection safety, doing very well in terms of targeting. But we need to do more in the hepatitis B mother-to-child transmission, harm reduction, and certainly in the diagnosis and treatment of hepatitis B and C, we have a long way to go. The success that we saw in June of 2020, where we were able to actually report on achieving the global target for 2020 of less than 1% hepatitis B surface antigen prevalence among children less than 5 years old. This success has been driven by immunization and birth dose immunization around the world, but has left behind Africa, and we need to really step that up. When we start to look at the 2030 target of less than 0.1% prevalence, we're seeing that we have a number, almost 51 countries, that are really ready and candidates for potential validation of elimination. In terms of the cascade of care for hepatitis B infection, in 2016, the latest data that we have, we're way far behind achieving our targets, and we have much to do for both the testing and treatment target. But we do know we've made some progress where we have 4.5 million people on treatment. And we hope when we do our updated data this year, we'll start to see an improvement in this area. There's been some missed opportunities where we haven't been able to use tenofovir as much as we should be. In terms of the hepatitis C, well, again, we have far to go in terms of reaching our targets. However, we have made some successes where we had less than 200,000 people on direct DAAs, or the direct antivirals. And now we have close to 5 million, but these are concentrated in our most high burden champion countries. And we need to scale that up and get more countries available to be able to deliver treatment. On the accountability of our global health sector strategy, we've been asked by our Director General to look at across these areas how we're faring. We know we've developed global goods and guidelines, we've provided technical support, we've produced a price tag, and that it would be cost effective to introduce these interventions. And now in 2020, we've been requested to develop criteria to validate the elimination. So the next piece, I'll be speaking a bit about that process. From countries, we've seen that we've been asked by and pushed by countries where we've seen excellent political leadership from Egypt, who are hoping to be eliminated within the next few years. We've seen Georgia taking the lead. We've seen countries like India introducing hepatitis programs into the domestic financing in UHC. Australia has shown a reduction in mortality already. And we have elimination plans from Africa, including hepatitis C elimination from Rwanda, as well as triple elimination starting across the continent, and negotiations of prices in Brazil. And with that, we're starting to see that there are national plans and impact indicators showing improvement. As long as we have both the input and the outcome, we see the impact. But there are barriers. We have limited funding, lack of transparency, high cost in some countries, fragmented procurement, limited integration of testing, and certainly inefficiencies and slow and limited product regulation. But we've seen the prices come way down. This is a slide from a CHI report. Where in Rwanda now, we're seeing a cost of a 12-week treatment down at $60 all-in pricing. And we need to see that transparency across all countries, especially upper middle income countries, as well as we need to see the same level of transparency around pricing for the viral load, where the prices are ranging from $70 to $9, and that's just not acceptable for a diagnostic that we know we can run for less than $10. In terms of measuring impact and program targets, these were requested of WHO to come up with some global criteria, a framework, and a governance process for the validation of elimination as a public health threat. And we hope that this framework will be useful. It will motivate countries to take action. It will provide guidance on how they can do it in different contexts. And we will want to make use of all available data that are in the country currently. We also know that not all countries have access to all the information, and that they have to develop either registries for mortality, registries that have attributable fractions for hepatitis B and C as we move forward. What you see here is what are the proposed framework and criteria for elimination. We both have in the blue impact targets and programmatic targets. For hepatitis B, EMTCT, we know that we're going to hold on to the less than 0.1% prevalence for less than 5-year-olds. But it's also very important that we reach at least 90 or 95% coverage of ANC among mothers who are coming in. So we're treating both the child and the mother. In terms of hepatitis B and C as a public health threat in the general population, the incidence reduction needs to be greater in hepatitis B, but when we translate these into an overall absolute incidence in mortality, we combine these and note that for the incidence, we're looking towards a less than or equal 5 per 100,000 per year, and a mortality of less than 5 or 6 per 100,000 per year, which is reflects that relative reduction. We also know that the mortality is much greater in hepatitis B, and so therefore we want to be able to push these programs together. If they're doing very well on hepatitis C, that the programs also consider how can they push monitoring hepatitis B and achieving the same level of outcomes and impact for hepatitis B. We also want for hepatitis C to ensure that we have the prevention targets, unsafe injections, blood safety, 300 needles and syringes per person injecting drugs per year, as well as a birth dose vaccine, especially in Africa. For hepatitis B, EMTCT, another area where we're looking is really at a path to elimination, as well as for general populations, where countries who have such a high burden, it will take them many, many years to reach elimination. We would like to be able to provide them with interim targets to show that they're moving towards elimination. Already, since we had our first meeting around Hep B elimination, we can see that we've had 4 regional validations committees developed in EMRO, Euro, CIRO, and WIPRO, and 2 regions have already started the process. So we know that this elimination of mother-to-child transmission is really within reach. So what will this mean for countries? We hope that the implementation considerations for elimination, having that framework in hand, will help countries to think about strategic information and data quality, developing strong laboratory and medicines of quality, and ensuring that the programmatic implementation has high quality and is balanced and is not overly burdensome. But we need to maintain equity, human rights, gender equality, and community engagement in this work. In terms of governance for the EMTCT element for either dual or triple elimination being HIV, syphilis, and hepatitis, we already have a governance that has a national validation committee, a regional validation committee, and a global validation committee that advises the DG at WHO about making recommendations for certification. Most of the work is done at the country and the regional level. Similarly, for elimination of hepatitis B and C, as well as EMTCT, we're proposing a national, regional, and global level approach. This appears complex, but it's just giving you an indication that there's feedback within the system, with the bulk of the work happening at the national and the regional level, with the global level really providing that recommendation to the DG to certify validation of elimination. So what are the next steps on the road to 2030? We're going to be conducting country pilots of these criteria, they are proposed criteria for the validation of elimination. We'll review and update these critical elements for our global health sector strategy for 2022 to 2030. We're likely to want to develop new absolute targets for 2025, but that has to go through a process. We'll develop and expand country, regional, and global capacity to monitor our progress towards elimination. And certainly we want to help countries implement their programs and build on both building back from the COVID pandemic and look for opportunities that emerge from the response. Certainly in conclusion, elimination of hepatitis B, C, and PMTCT and mother-to-child transmission of B is within reach. And we just know what we need to do, and now is the time to make that public health push. So with this, I thank you very much for inviting me. I will stop here. Thank you.